department. We see that we have participants which were already present 2 weeks ago to listen to the webinar on bioIDM in the emergency department. We also have new faces today, so welcome to everybody. This webinar will be recorded and later available online on demand. During or after the webinar, you can type your questions in the field for the text on the lower right side. And please, when you write it, we have a request from our presenter that maybe you can write from which country you are, as emergency departments are arranged slightly different from country to country. And with that, I would like also to introduce you our presenter, Professor Salvatore Di Somma. Professor is the expert in emergency medicine and an expert in biomarkers intended for the use in the emergency department. He is a professor of medicine, chairman of the Postgraduate School of Emergency Medicine, and director of educational programs at the University La Sapienza in Rome, Italy. He is the author of more than 300 papers in the field of acute cardiac care, cardiology, and emergency medicine. Professor is the vice president of the Great Network Association. It is a worldwide academic research organization aimed to develop research in the field of acute diseases. And Professor Di Somma is also considered as a worldwide expert in the utility of biomarkers and new technology innovations in acute diseases. Today, Professor Di Somma will talk about the challenges of recognizing and managing patients with acute kidney injury in the emergency department. And without further ado, I would like to give the word over to Professor Di Somma.
Thank you. Thank you very much, Alexandra, for the nice introduction. It's really a pleasure for me to be able today to address an important topic, that is the problem of detecting immediately in the emergency room acute kidney injury. And I will try during my 25-30 minutes presentation to try to go in the new insights on how we really be able to improve our ability to detect acute damage in the emergency room in many acute disease. These are my disclosures. So I will go through these three topics today. Why we really need to be able to detect immediate AKI in the emergency room, probably using biomarkers. Then I will concentrate on the value of new biomarkers of kidney damage, that is Proenkephalin, penKid, and then I will conclude my presentation with the case report in the emergency room. Now, we know very well that when the kidney is added in any acute disease coming from the heart or from the lung or from the liver, the mortality is going to be increased. So this means that the kidney is making the difference. And so we should really check in the presence of acute disease if the kidney is injured or not. Now, there is a worldwide increase in kidney damage, both acute and chronic. And this is expected to even rise more in the next decade. So there is a lot of need for trying to stop this increase. Moreover, when the AKI, acute kidney damage, is occurring in acute disease, there is a need for increase in dialysis, and of course is also linked with increase of costs. So we are talking about a very, very important acute disease where you should fight more in the future. Now, what is really important to know that the incidence of acute damage of the kidney is quite high in the hospital because it's around 22%. And when you go in ICU for people very critical, the percentage is around the 60s. And again, it is really important to understand that when the kidney is involved with many acute disease, people admitted in the hospital, the mortality is again increased, but not only that. So it is very important to recognize early, even in the subliminal kidney damage, in any case to rule in the presence of AKI. In this case, you have a lot of therapeutical different options to immediately go to do, or you can having rule out means that it's also important because although the patients have any kind of acute disease such as sepsis or acute heart failure or burns, the kidney is normal function. That means that you can have standard therapeutical approach. So there is a lot of therapeutical consequence that you should make in activity when you have the detections of early acute damage of the kidney. Again, this is really the job of emergency physician, rule out and rule in. You know how much important it is for emergency physician not to waste time in rule in. Take, for instance, acute coronary syndrome, but was again acute kidney damage, like we showed in the past, the presence of a sepsis. Because if you are going to be able immediately to go a very good rule in, you are going to improve the patient's outcome. Why? If you are going to delay rule in, you are going to increase mortality and morbidity of the patients with a lot of consequence. Again, also a delayed rule out, that means you take more time in order to exclude the acute disease and acute damage of the renal presence. You are going to increase not only the mortality, but also to increase the anxiety of the patients and also, again, the cost of the healthcare system. So you really, to be a good emergency physician, you be fast and accurate in ruling in, rule out any kind of disease and also AKI. Now, we addressed already that the percentage of AKI in the setting of hospital is around 22% in the world and even 57% in ICU. How much is the incidence of AKI when the patient present to the emergency room? This is quite challenging. We have two papers just published, one paper in critical care around 10 years ago, where in our hospital in Rome, Sant'Andrea, we were able to demonstrate that the percentage of patients having AKI of all comers in the emergency room is around 7%. It seems that 7% is low when you compare over 57% in ICU. But for instance, you know that there are millions of people coming in the emergency room worldwide. So 7% of millions and millions is much more than 22% or 50% of 10, 15 admitted people. Now this is for European standard. When we go to more different population, such as Asian population, this is a paper that just came out from the GREAT network. We did an important study in 5 emergency rooms in Thailand, India, Singapore, Korea, and Australia. And here, the percentage, 10 years later, this was the last year, just published recently in Annals Laboratory Medicine, is increasing, is around 12%. This means that there are a lot of number of patients coming in the emergency room having acute kidney damage. But what is important, if you look different population, multicentric in Asia, where probably diabetic patients are more prone to have AKI, there is an increase of numbers. So we are expecting, again, a lot of people in the emergency room in the future coming with the presence of AKI. Now, the issue is here, how can I be able to detect immediately the presence of acute kidney damage in the emergency room? First of all, let me tell you one story. People with AKI have no symptoms. In other words, the kidney does not talk, while the heart is talking, because patients with the heart disease can have a shortness of breath or chest pain. So there are a lot of symptoms that can induce the emergency physician to immediately detect the presence of acute coronary syndrome or acute heart failure, while since the kidney is not talking, it's much more difficult to detect the presence of ongoing AKI in patients with acute disease. Anyway, from these slides, that is again from our recent paper, it is clear that there are two main diseases that are linked with high possibility to have AKI, that are sepsis and acute heart failure. And you know very well that these kind of disease are representing a lot of patients every day. And when you go to see which are the reasons why patients in the emergency room can have AKI, the most relevant is the use of reagents for contrast media analysis. Anyway, also from these slides, it is very clear that from a clinical point of view, to be able to detect AKI in emergency room in acute disease is quite challenging. Now, since there is a kind of clinical difficulties, we should go to look for the guidelines criteria. The most used definition criteria of AKI are roughly AKIN and KDIGO that is actually the more used. Which is the issue? In the emergency room using KDIGO, you need to have 48 hours creatinine level before arriving, because you need to show an increase of 0.3 milligram deciliter of creatinine in 48 hours to confirm the presence of AKI. And the problem is that this is also been linked with the kind of reductions of urinary output during the few days before. Now, take the example that a patient is coming in the emergency room for any kind of acute disease, sepsis or acute heart failure, and you ask the patient, could you please tell me how much was your creatinine 2 days ago? And he's looking to you and say, what are you asking me? How can I know how much was my creatinine 2 days ago? So it's just to demonstrate to you it is quite difficult to make a diagnosis in the emergency room of AKI based on KDIGO. So this is really something that we have to think differently. And also, creatinine per se is a poor biomarker of, although it's the best one we have, it's really not enough because it's influenced from a lot of different organ damage, such as liver, such as muscle. So I think creatinine is the best we have, and it's still to be used, but there are a lot of caveats. Moreover, when creatinine is increased of 0.3 in 48 hours, already 50% of functional glomeruli are lost. So it is too late, and you really want to immediately to check the ongoing damage before 50% of the kidney function is lost. Now, having said that the creatinine takes 2 days to rise in order to detect, based on KDIGO criteria or high-flow AKIN, the presence of AKI, you have not 48 hours in the emergency room. You really need immediately, when the patients arrive, to have a biomarker, such we have high-sensitive troponin for acute coronary syndrome that now 1 hour is going to tell you this patient has or not acute coronary syndrome. It has improved a lot the patient outcome with ischemic acute disease. So at the end of the day, we really need new biomarkers that are mirroring the damage ongoing on the kidney to stop and reverse this. In other words, we need a troponin for the kidney. So why we need this? Because in the acute setting, when the damage of the kidney is going on, there is a subclinical domain here in this green zone where you can be able to detect in the blood of patients the presence of some biomarkers that are already before creatinine rise, able to tell you there is something wrong in the kidney, so you have a different decision, because you really then have a progression of this subluminal initial damage in the kidney that is going to be recovered, possibly, depends what are you doing here, or there is a lot of damage going to for the patient to need for dialysis. So really you need to go in this green area before this red area to be able to detect immediately the presence of acute damage. There are a lot of AKI biomarkers that have been experimented during the last decades, and of course we can recognize stress and damage markers, but at the end of the day, no one of these should be really utilized. So I need a biomarker that is reflected immediately function of the glomerula like creatinine do. The problem is creatinine does it in 48 hours and also influenced by many other organ damage. Which are the two biomarkers that are currently of utilization into the possibility to immediately detect functional disease in the kidney? Cystatin C and Proenkephalin. There is not the a problem that I put in red Cystatin C and Proenkephalin in green. Why? Because we already studied, that was a paper published already 7 years ago, showing that cystatin has of no utility in the emergency room. It is a paper we published showing that if you use cystatin in trying to detect AKI in the emergency room, there is no advantage compared to creatinine. So definitely in the acute setting, Cystatin C is not really better than creatinine to detect AKI as soon as possible. Now, I will take the next part of my presentation, try to show you how the new biomarkers proenkephalin, penKid, should be very useful in the emergency room for early recognition of AKI in many acute disease. First of all, which is proenkephalin? Enkephalins are small peptides that stimulate kidney function. And this is really very clear that there are receptors in the kidney that are really linked to activity of enkephalin in order to be detecting the function of the kidney. And now, since proenkephalin is a prohormone, where is again linked with the function of the glomerula, you can detect in the blood the stable fragment of a proenkephalin that is penKid. So thanks to this sandwich immunoassay, we can really be able now to measure this stable fragment of a proenkephalin, penKid, that is mirroring the ongoing real-time kidney function. And this is really what really we need, and I will show you in the clinical practice why we can use penKid in order to detect what is going on in the kidney as a functional disease. First of all, for this very complex ioxazole or iotolamide clearance that are the very well-known system to measure the true glomerular function, that is very clear that the proenkephalin is exactly mirroring the glomerular function. This is really important. While, as you see, the area under the curve of penKid to detect AKI is around 0.97. So there is no doubt that using proenkephalin, penKid, you really be able into the emergency room, but in any place, fighting with the possibility that the patient has AKI to detect the occurrence of that in many critical conditions. Which is the normal value of proenkephalin penKid is around 80 picomole liter. So from this LT cohort in Malmo diet cancer study in Sweden, is very clear that if you have a value of penKid of 80 or below, you are okay in this normal function. If it is increased, there are damage. So you really can detect like creatinine normal value. Now, let's go in details. Where are the clinical critical conditions where you can use penKid? These are two papers, one center in Korea, where we were able for the GreatNet to show that patients coming with the sepsis in the emergency room before 2 days of developing, based on KDIGO, the presence of AKI, already proenkephalin was able to detect were greater than 80. On the other side, this was confirmed but large multicentric study. So this means that if you have a cutoff of a penKid of 80 and the value is the green, so below 80, you are okay. While if it is greater, the more is the damage of the kidney, the more is the increase of penKid in the septic patient. What is important also that in other critical conditions, such as patients with other need for admission in ICU, you can detect not only AKI using proenkephalin and also rule out AKI, but also you can detect subclinical AKI. What does it mean, subclinical AKI? It means a patient come in the emergency room with apparently normal creatinine, where proenkephalin is already increased. It means that it's ongoing damage that if you are not able to stop, is going to be linked, like we see in this part, to mortality, for instance, in sepsis from our paper. So there is really important to not to detect the presence of AKI, but to stop the progression, making able, thanks to proenkephalin penKid, to detect the occurrence of acute renal damage. There are also a lot of clinical suggestions, because if you are going to use penKid in patients with acute disease, you can predict that this is a big cohort of multicentric study from Frog ICU and Adrenos patients with sepsis, where this is a very clear possibility that if you have penKid below 80, these people in green zone are not needed for the need for dialysis in the next 40 hours, while penKid at elevated more than 80 at arrival in ICU is going to link it with the need of dialysis. So there is really a lot of information on the clinical outcome, mortality, and the need for dialysis. Let's move to other acute disease where you really want to know the kidney renal function. That is, for instance, cardiogenic shock or acute heart failure. In these two papers, we were able to demonstrate that in cardiogenic shock, when the patients present with increase in proenkephalin penKid, the mortality is higher compared to the patients that has no kidney damage. Most importantly, in two centers in the Great Network in Sweden, Malmö, and in Rome, you see that again, in acute heart failure subject, patients with having proenkephalin greater than 80 were having worsening renal function. And you know very well that the worsening renal function, that means deterioration of renal activity during acute heart failure episode, is always linked from these 10 years experience with worse prognosis. So the fact that patients are in the emergency room with acute heart failure and the kidney is going to be deteriorated means that the patient is going to die. And this leads to the concept of cardiorenal syndrome type 1. What is cardiorenal syndrome type 1? In acute heart failure, there is a damage of the kidney because there is a decrease in perfusion. And this is also to increase the renin-angiotensin activity that is still making a vice circle, determining even worse heart function. And at the end of the day, any hospitalization linked with acute renal damage in acute heart failure is linked with increased mortality. So you really want to check the kidney in the situation of acute heart failure. And this is a paper we publish with our group, with the Boston Harvard group, demonstrated that we have patients with emergency room coming in acute heart failure. If there is no deterioration of renal function, these people are going to be okay. While in the incidence of acute renal function in patients with acute heart failure is around 25%. And the mortality and the length of stay, hospitalization, and so events are quite increased if there is renal damage in patients with acute heart failure. So again, you really want to watch the kidney in the presence of acute heart failure. Now, which is the best predictor that is able to tell emergency physician or ICU people, every people working with acute heart failure is proenkephalin. It is the best predictor of ongoing worse renal functions and the mortality compared to natriuretic peptides or plasma creatinine in patients with acute heart failure. This is a study published in Journal American Cardiology some years ago from the Great Network. Why proenkephalin is increased in acute heart failure mirroring kidney dysfunction? Because heart failure give a reduction diuresis, reduction of perfusion of the kidney, cardiac output. So there is an acute damage into the kidney that is going to deteriorate to, let's say, a kind of response to kidney functions. And so you have an increase of proenkephalin that is going to mirroring this ongoing damage. So you can be able to use a different approach, such as less or more diuretic or vasodilator or fluid and something like that. So there's a lot of a possibility that detecting, thanks to proenkephalin, acute worsening function of the kidney into acute heart failure is going to give therapeutical implication. There are other clinical acute conditions that are linked with the possibility of utilization of penKid. You know, there is a lot of situation in the emergency room where you need radiographic contrast procedures. For example, in patients where you have a suspicion of a pulmonary embolism and the patient has a kind of a mild increase of creatinine, and the radiologist tell you, I'm not going to make any kind of use any kind of a contrast agent because of the risk of acute contrast AKI. But from this paper from Switzerland, the group of Christian Müller from European Journal of Clinical Investigation, is very clear that you can check proenkephalin before performing the contrast procedures. And if a penKid is going to be normal, you are fine. You can send the patient to radiology. Don't worry, I'm monitoring proenkephalin. You can definitely do the contrast utilization in this patient. So in the emergency room, I'm sure that is of great utility, especially in the acute setting. Now there is other disease such as burns. In burns, that is also a situation where you really want to see the survival rate. Proenkephalin, that is mirroring ongoing acute damage of the kidney, is linked with increased mortality. And also in patients with burns, you can monitor a penKid, because this penKid is higher at arrival, but it's going to reduce. You have a better survival compared to the patient with high penKid, still high penKid after 3 days. So there is now another concept, like we presented with the bioadrenomedulin last time, that you can use proenkephalin not only for detecting AKI, but also mirroring the ongoing damage in the kidney. Again, this concept of dynamic, let's say, behavior of a proenkephalin is going to, this study we published in the sepsis show that if you have a penKid good at arrival below 80 and you maintain this level below 80, survival rate is quite high, while if you are going to have an increase of proenkephalin after admission in septic, mortality is going to be 50%. And this is really important because also in patients with septic shock, this is really need for monitoring proenkephalin to predict the outcome of the patient. I just would like to use this slide to give important home take message. So before starting any kind of decision in patients with acute disease in the emergency room, such as sepsis or acute heart failure or burns, please check proenkephalin penKid, because 2 days before creatinine, penKid elevated greater than 80 is already mirroring ongoing impaired kidney function, AKI. And so once you have detected this, you can do a lot of therapeutic different decision, and you really want that the penKid is elevated, you want to go down to restore the kidney function. This is important. While with the creatinine, you cannot do this, because when creatinine is becoming greater than the arrival and the increase of the kidney critical criteria of 0.3 or more, already 50% of the glomeruli are lost. So there is really room for utilization of these biomarkers, like we do for troponin acute coronary syndrome, to detect ongoing acute damage and to restore it, monitoring penKid. I think this is really important take-home message. Now, what do we need in the emergency room? There is always a worldwide consensus that into the overcrowding situation, you need immediate to have possibility to assess imaging and laboratory testing. So there is no doubt that using point-of-care biomarkers, you can improve our clinical decision in the emergency room. And now the good news, like we have really demonstrated for bioadrenomedulin, that using this IB10 system point of care, you can have access to penKid value in 20 minutes using whole blood. So you are checking the patients, for instance, with the sepsis, you are thinking there is kind of ongoing acute renal damage, check penKid using Nexus, you have 20 minutes close to the patient, you can make the final decision. And from our results in this preliminary study we are doing in San Giovanni Hospital in Rome, using this IB10 system proenkephalin, we were able to demonstrate a very good relationship between creatinine and penKid, but most importantly, in patients coming in with the reduction of diuresis, penKid was able to detect the ongoing kidney damage. So this demonstrated the utility of these biomarkers in the emergency room. Now, in the next 5 minutes, let me address the important value of demonstrating how can I use in clinical practice every day in the emergency room of proenkephalin to detect AKI. So we are talking about a man, 82 years old, coming to the emergency room because of a worsening of cognitive status. You see that at arrival, at triage, everything was quite okay. Blood pressure, heart rate, breathing rate, saturation, temperature. And she was bring to the emergency room because the daughter told to us that he was having a lot of diarrhea during the last 4 days, and the confusion was increased coupled with the attrition. So this was really the reason the patient arrived. In his anamnesis was atrial fibrillation, type 1 diabetes, dementia, chronic ischemic heart disease. I was taking anticoagulant and insulin. Now, as we do every day in this case, we check the situation of clinically, but then we ask for laboratory tests, right? And from a laboratory test, nothing was really bad. Apart this C-reactive protein that was really specific. So it seems that although the patient got some clinical deterioration of cognitive status and was dehydrated, nothing was so bad. And the creatinine, look at that, was absolutely normal. Then we checked proenkephalin. As a matter of fact, proenkephalin was very high, twice greater than normal value, around 160. And what is important that at that time, we are not using intention to treat proenkephalin, and the creatinine was normal. We were not thinking about ongoing AKI. That penKid using IB10 was already mirroring. What's happening to these patients? At this moment, I don't know why there was decision to use antibiotic treatment, and the fluid, probably because of the dehydration anyway, was using the empirical antibiotic treatment. And well, as a matter of fact, 12 hours later, the patient presented anuria, was clear reductions of blood systolic pressure, increase in fever, and was a deterioration for a need for norepinephrine infusion. And when we did a second laboratory testing shot 20 hours later, there was a clear increase of creatinine mirroring acute kidney injury, and the patient was also in septic shock, also because procalcitonin was elevated. So this is really a true case where we really think that proenkephalin was able to detect the presence in these patients with ongoing damage of the kidney much before creatinine was normal. So it's a clinical case of subliminal acute kidney damage that should have give information. For instance, in these patients, don't to use antibiotics that are probably potential nephrotoxics. So I think this is a clear case where proenkephalin showed how is able in early phase to detect the occurrence of renal damage before creatinine rise. And this is also, like this paper showed, that an early intervention for nephroprotections that was being not done in that case is linked with improved survival. Now, just to go to conclusion, it is really clear that the incidence of AKI is around 22% in the hospital, 57% in ICU, and in AD is around 10%, but 10% of millions. You have to know that in Rome, we have 2 million people come in emergency room every year. So 10% of 2 million people is a lot of patients that can benefit of an early detection. Because if you are able to reverse the initial subclinical kidney cell injury, you can really do a better job for your patients. So it is really crucial that can enhance the biomarkers that are using to rule in, rule out AKI to make definitely important early detections of damage much more than faster than creatinine, and you can do to going to be able to make appropriate therapeutical different options. At the end of the day, proenkephalin is able to mirroring the healthy status of glomerula because it's used as a routine concentration instead of a creatinine. We can discuss about that. But most importantly, if you have an increase in raising a level of proenkephalin penKid, it means that in disease states there is a clear ongoing impaired kidney function. And then this leads to the fact that you can really use now proenkephalin to measure ongoing real-time kidney function different from creatinine. And it is important that if, for instance, you have inflammation and you want to use a biomarker such as NGAL, you know that NGAL is a caveat used in patients with the sepsis because it's influenced by sepsis, while proenkephalin is not influenced by comorbidity. Again, is able to predict 48 hours before the ongoing damage, the presence of AKI, and also the need for dialysis. And this is really a possibility to use proenkephalin detected immediately in patients at risk AKI, such as sepsis, acute heart failure, shock, BARS, or need for contrast agent, in order to make better clinical decision. And also, I think really would be remarked that you can monitoring if you start in the emergency room the kidney function to see how is ongoing the damage in the kidney. At the end of the day, you can have a lot of therapeutical different decisions. I think that what is you really the need for biomarkers in the emergency room to have clear therapeutical different options. And in fact, detecting AKI very soon, you can have a lot of possibility to avoid nephrotoxic agents such as antibiotics. You can have a possibility to optimize fluid administration and also, for instance, to check the possibility to better disposition in ICU. But, and this is what is the possibility now to be able to immediately detect ongoing renal damage in patients with acute disease in the emergency room. But remember, you don't want to use a single number. You want to use the biomarkers into the clinical definition that is always really important because you want to insert laboratory testing, especially if you're obtained by a point-of-care system such as IB10 for penKid in order to make different options. Because at the end of the day, you would like to couple biomarkers in the emergency room with the skill of emergency physician that always are a good clinician in visiting the patient. And with that, I'm going to stop my presentation and be very happy to take any questions.
Professor, thank you very much for your excellent presentation. It was a very clear story and interesting patient case. Dear attendees, please can you type your questions? We already have one question in the blog. May I use an opportunity to ask a question from me regarding the patient in your patient case? So based on the penKid value, if you had that value and used that value for a decision making, what kind of antibiotics would you be using instead of those antibiotics which are used there, or maybe no antibiotics? So if you could comment on how your therapy would change.
This is a very good question because as you saw, these patients, I don't know if it was a clear linkage between that use of antibiotic and the kidney damage, but I really suppose that the antibiotic was not good for the kidney of that patients, because the people taking care of the patients were not looking at proenkephalin, they were looking at creatinine, so they were thinking to be free to use any antibiotic. First of all, in that case, I am not sure that was the case of antibiotics. In any way, although creatinine was normal, if penKid was already was able to mirroring something wrong, ongoing renal function, I was using, if I need, antibiotic without any kind of nephrotoxic activity. So at the end of the day, this is really clear case where I can use antibiotic or not, and I don't know in the case was why they used it, but probably one reason was that. But definitely the two antibiotics that were used they had some nephrotoxic activity, but the physician used that antibiotic because the creatinine was normal. So there was no way to understand that something was wrong, like proenkephalin was able to detect.
Very interesting. And a theoretical question, the use of penKid and bioIDM in emergency department, do you think it could reduce the use, the unnecessary use of antibiotics?
This is a very good question again. Of course, in sepsis, you need to use antibiotics. The guidelines recommend you use antibiotic in 1 hour. But assuming that you have, for instance, bioIDM elevated, that means the patient has not only sepsis, but a value, I don't know, around 120, and having already the risk to go in a septic shock, and the proenkephalin is elevated as mirroring the ongoing kidney damage, I can use probably a little bit more fluid, right, to exclude the kidney damage, and I can use, in this case, antibiotics that have been recognized to be not nephrotoxic. So I really recommend, in the case of a sepsis, where you really need to use antibiotic, right, to check the both, because proenkephalin is going to recommend to you using antibiotic that has no nephrotoxic activity. On the other hand, bioadrenomedlin, like we showed last time, was able to give you the possibility to give more fluid and immediately, for instance, start norepinephrine therapeutical agent that are going to couple together the benefit of a fluid and the selected antibiotic. So there is really room in sepsis to use both together.
Thank you. Very interesting answer. I think I should step back and read out the questions we get from our attendees now. And the first question is actually related to the fluid management in the patients. So creatinine measurement is affected by various by variations in the volume status. So the diagnosis of acute kidney injury may be delayed or missed in patients with significant fluid overload or fluid shift. So what's your comment on the influence of fluid volume on penKid measurements?
Okay, as you saw, penKid is very stable, it's not influenced, but definitely I can have a suggestion in the case, for instance, of acute heart failure, right? A patient's having a lot of fluid increase in the body, right? And also in the kidney, that is not only the decrease into the glomerular function, but there's also a kind of congestion from the capsula. So there is also fluid in the kidney. I can never use more diuretics in this case in order to detect the pressure on the volume in the kidney. So I can use diuretic dosage properly in the case of worsening renal function, or I can go for immediately dialysis before the kidney is going to be totally deteriorated. So also in the case of acute heart failure or for sepsis, you can have different therapeutic fluid treatment and diuretic treatment looking at the preliminary subclinical damage of the kidney in the early phase, because you have not 48 hours to make therapeutic decision on diuretic of a fluid in acute heart failure or sepsis. So the fluid therapy is definitely a one important chance you can have to go with the utilization of penKid to increase diuretic or reduce diuretic, to increase fluid or reduce fluid depending on the clinical condition. So the fluid therapy is really a perfect example where I really would like to check the ongoing subliminal AKI in order to restore the clinical glomerular function, increase it or not diuretic, increase or not fluid administration.
York, please could you comment whether your question was answered? I think there was another component in the question. Professor, do you think that fluid overload or administering a lot of fluids to the septic patient can lead to dilution of the biomarker in the plasma to be measured?
No, absolutely not. There are we have a lot of patients that have been monitoring during the fluid infusion in the paper that we publish, where when the patients arrive with the sepsis and you take proenkephalin and you mirroring the same amount of fluid or increase the fluid, proenkephalin is not affected. So dilution is not definitely, influencing the proenkephalin value. Definitely not.
Thank you. And the next question. I hear new kidney biomarkers talking about detecting subclinical AKI. What about penKid? Is there any data?
Yeah, I mean, there are some, I don't know if we want to come back on some slides, but it's some slide demonstrating clearly. For instance, let me just take our patients, right? Just, here. This is already subclinical AKI. What means that the creatinine was normal. So we were not able to detect the AKI at arrival like it is always in the emergency room. Here was already subclinical AKI that went to be clinical AKI 24 hours later. So this is really what the penKid is able to detect. And of course, there is really a window, like I show you at the beginning, where you can detect, because proenkephalin is mirroring real ongoing glomerular function that the creatinine is not able to detect, because creatinine takes at least 24 hours to rise. So again, this is a situation where there was an ongoing glomerular dysfunction that you can call subclinical AKI, but means that there is an initial damage, like high-sensitive troponin does in the case of acute coronary syndrome. It is a kind of a subclinical damage and being able to reflect the ongoing myocyte damage. So this is a clear case. And then you can have AKI right here, because there was a damage. But even if a creatinine, this is the case, was normal, okay, here, 24 hours later, and the penKid was still elevated, this is subclinical AKI. So this is an important concept. To summarize, if there is an ongoing penKid elevation at arrival 24 hours for it is not linked with the creatinine rise, it is not AKI, it is a clinical, subclinical AKI. Means that something going wrong into the function of the kidney, but is not already AKI. While if I have a creatinine rise, like in this case, that is increased more than 0.3 of a creatinine that was normal at arrival, this is AKI. So I just want to make sure that everybody understands this concept. So if you have constant increase of proenkephalin without jump of creatinine in next 24 hours, 48 hours, you have subclinical AKI. If you have increase of creatinine 0.3, like KDIGO criteria suggest, there is AKI. Is that clear now, Alexandra?
Thank you. Very, very clear answer. So do we have, we have more questions. So what is the ideal testing frequency, especially for the first 12 hours of admission? This was actually the question I also wanted to ask you to your colleagues. How would you recommend, what clinical signs would be the trigger for you to measure penKid in the patients?
Oh, very good question. Of course, the first one is at arrival in all acute disease that I show, right? So time zero, when the patients arrive with the suspicion of sepsis of acute kidney damage, that is clinical criteria, you should check. So you need basal point, right? Time zero. Then I suggest to repeat at least every 24 hours. Because again, and then to couple with the creatinine. So you don't want at the moment exclude the creatinine, but you want to check every 24 hours for the next days. And just to check if there is an increase, it's going to be reduced, or there is an increase that remains stable increase, or if there is a low value that remains low value. So I suggest every 24 hours for the first 4 days. And then you can check if everything is okay, you can maintain the patients in that stable. But in the first 3-4 days that are the window where you are to change your therapy, I really recommend to do proenkephalin every 24 hours together with the creatinine.
Are there any other conditions apart from the acute heart failure and sepsis in the patients in the emergency department where you see the penKid measurement is useful?
Yeah, first of all, again, burns. As I show you, there are data in burns that I would like you to here. This is also very important. Need for radiographic contrast procedure. This is really probably the most frequent need, where in many patients where you are going to ask for radiographic contrast procedures, and where creatinine is of no utility, proenkephalin is of great utilization. This is really something in the emergency room occurs every day. And this is really important, but I really would like also to recommend in case of burns to use. In any case, these are all the situations that are critical, crucial condition, but there are any case, what I use to ask the doctor, the emergency physician, do you think that this patient, because he's diabetic, because has acute coronary syndrome, you won't check the kidney? Yes. So the acute conditions that I showed are the situation where we have data recommend. But any case where you really want in acute setting to check the kidney function. Creatinine is using as a routine in all patients coming in the emergency room for any kind of a condition. All the patients coming with acute coronary syndrome, they do creatinine because they are going to do coronary angiography, right? It's better to use proenkephalin because you are going to have online, ongoing, real-time kidney function that the creatinine is not really able to mirroring. Is that clear? So in all acute condition where you want to check the real ongoing glomerular function, please use proenkephalin together, or at least in the future. Let me tell you, I don't want to be too much enthusiastic, but in the future, I think that the proenkephalin is going to substitute the clinical practice creatinine.
Wow, thank you. That's a very, very nice prediction. Very nice outlook.
I hope so, but of course, it depends on the experience you have.
Yeah, we also hope so too. So we get more questions now. For the renal replacement therapy, would it be more often than every 24 hours? And actually, regarding renal replacement therapy in Italy, do you use renal replacement therapy in the emergency department, or do you need to send the patient to the ICU?
No, we use, and even we have renal replacement facilities in the emergency room because, for instance, you can do ultrafiltration, right, in acute heart failure patients, and you need to do as soon as possible. So in that case, where you have a worsening renal function and you have the kidney that is going to be impaired, I really would like to use ultrafiltration sometimes. So we do use in the emergency room the possibility to ask nephrologists to come for a consultation, and sometimes looking at the kidney and making that there is something, let's say, ongoing, but creatinine is not able to detect. So using proenkephalin, you can predict the need for the ongoing need for 48 hours dialysis, and this is the case where we can even do with the portable dialysis in the emergency room.
Thank you. And we have one question. Do you use penKid in routine in your hospital?
Yeah, actually, we are starting using IB10 in routine. In all patients, of course, now the study that we are finishing in the emergency room is on septic patients, but in the future, like we showed, we're using the point of care with IB10, like in this case, you don't need to send anymore the blood sampling to central lab. You can do easily penKid, you can do rule out, rule in acute AKI, and then you can start different therapeutic options. So we are going to start as a routine using IB10. This is the value of a point of care. And then, of course, if everything is okay, you make the rule out. Let me tell you, Alessandra, rule out is much, much important than the rule in the emergency room. So you take out the 90% of the people having no AKI, you are going to do the regular standard therapy, but you really want to check the rule in 10% is going to make a different therapeutic approach.
Thank you. Another very interesting question we have, is there a European recommendations on the way?
I mean, actually, of course, I don't know, for instance, if you look for sepsis, recent 2021 campaign, acute heart failure recommendation of bedside cardiology, they just say, watch the kidney, right? They don't recommend at the moment any kind of biomarkers because, again, it's challenging, but they recommend to watch the kidney. What does it mean? Actually, it means to control creatinine, to control urine output, to control sodium and potassium, and this is reasonable. They don't recommend any biomarkers. But the story of biomarkers is a kind of philosophy. It took 25 years for BMP, like we discovered many years ago, to be now in the guidelines evidence 1A for acute heart failure. So I think we should really not wait 25 years to put in the guidelines acute kidney biomarkers as soon as possible. But I think it is the time now that to think about to include biomarkers in recommendation to kidney watch in many diseases, looking at biomarkers, particularly if in the clinical daily practice proenkephalin is been demonstrating of utility, definitely it will be in the guidelines in the future. So this is also a philosophy of biomarkers that should be accepted. Like we accepted so far for high sensitive troponin, for acute coronary syndrome, such as for BNP and TPRO-BNP for acute heart failure, or procalcitonin for infections. I think it's time now to increase the possibility to utilization of kidney biomarkers.
Thank you very much. And if I may to add something from the point of view of the company, Peter, to your question about European recommendations, we do approach local groups that derive recommendations, for example, in Italy, or we presented our biomarkers to the NICE in UK. So we are working in that direction, but as Professor mentioned, it takes time, and also it is about the philosophy of accepting the novel biomarker, but we are working on that. And we have one more question to Professor de Somma. You might have mentioned that before, but what was the cutoff for penKid that you used to rule out the AKI in the emergency department?
The cutoff is very simple.
Mm-hmm.
Yes, the cutoff is very simple. It's 80. So if the value is 80 or below, the renal function is normal. Greater than 100, there is an ongoing kidney damage. So what is also good in biomarkers, that you have a very simple single cutoff that is 80 picogram ml. That means if the patient has a value below 80, is normal, okay? If there is greater than 80, let's say 100 or more, there is ongoing kidney filtration damage.
Thank you. Talking about the cutoff value, you use the cutoff value of 80 and you look at the biomarker value. Do you use in the emergency department the estimated GFR calculated from the formula? Because we have it already available also for penKid.
Yeah, I mean, yeah, I will show you the calculator. I think is one of the first slides if you want. I can come back very quickly.
But in your fellows in your hospitals, do you use the cutoff of the biomarker itself, or do you already use also the formula?
No, we use the cutoff per se.
The cutoff. Mm-hmm.
But this is here, right? You are
Yeah,
the next one. Sorry. No, that's one.
Yeah,
so,
but that's okay. I just wanted to know because
we are quite happy using the single cutoff.
Like a single cutoff.
Yeah, here. I think you are going to think about it, right?
Yeah, so we have one more question. In CRF chronic renal failure, is 80 the alarm value or increases?
No, this is another advantage compared to NGAL. You know, I got a lot of experience 10 years before penKid was arrived using NGAL. And if you have a patient with a chronic kidney damage, and you are going to be measuring NGAL both on urine and in the plasma, there is a lot of false positive of NGAL, mirroring that this NGAL is coming to the fact that the patient has a chronic kidney disease, okay? So NGAL is not able to detect acute damage on chronic damage, while penKid is absolutely to do this. Assuming that the patient is coming in the emergency room with any kind of acute disease such as sepsis, and he has already a story of a proenkephalin, of a creatinine that is elevated because of chronic kidney damage, assuming there's a creatinine of 2.5 over 3, right? And you have a proenkephalin elevated greater than 100, let's say 120. This is a very serious patient. That means acute kidney damage on chronic kidney damage. So the mortality of this patient is very high. If the patient has chronic kidney damage, assuming creatinine 2.5, and the proenkephalin is normal, this means there is no acute damage on chronic function of the kidney. Is that clear?
To me, it's clear. The attendee that asked the question, Giordo, did it answer your question? If yes, I would like to go to the next question. Interesting one. Do you think the low penKid values have any special meaning?
No, I mean, it's very special because it's ruled out. In the emergency room is a great value, and it's even more than rule in. Again, assuming that the incidence of AKI is around 10%, in 90% of people that you have penKid below 80, that means that the glomerular function online is okay. You can use any kind of drug without any risk of impairing kidney function. So it's a great value of a normal penKid, even more than elevated. So rule out the issue in the emergency room is more important than rule in, Alexandra.
Yeah, Peter is writing he means very, very low values.
I mean, no, because at the end of the day, if it's increased, let me go here to the, I mean, at the end of the day, in the normal range here, from here, you see, there are also value of 1, 5, 10 that are normal values. See these Gaussian curve for marmoset cancer. So the problem is here. This is a normal range from, let's say, 5 to 80. It's very clear. The message, you see, there is no damage, even with the value is 26. Mm-hmm. But the majority of people, they have a value of around 80, like you see here. So low value of penKid are okay.
There was data available, Peter, that very low penKid values are associated with a higher risk of breast cancer, but I think it is a completely different application, which is not relevant for emergency department or the ICU. No, so if Peter Blom that asked the question meant those very, very low values, but this is a different application.
I don't know which are the application. I don't know this breast cancer utilization, but again, there is a very low value are in the normal range.
Yeah, very good. Thank you. Do we have more questions from the attendees? Because at the moment, I think we have addressed all of them. And the presentation was very clear, very interesting, with a real patient case. So thank you very much, Professor, for your effort, for your time, for presenting.
I have also to say thank you to SphingoTec to make this opportunity to discuss and the number of the questions that have been raised means that there is a lot of interest on the topic, right? And how can we really solve a true problem in the emergency room to early detection of AKI? And it seems that Proenkephalin is very promising in this sense.
I would also like, on the behalf of SphingoTec, to thank our attendees and thank them for very interesting questions, because the Q&A session is what really adds the valuable edge to the webinar and allows to answer the questions live. So thank you very much, everybody. And we hope to see you again on the 31st of March. There will be the third webinar in our series on the utilization of various biomarkers, novel and already well-known standard biomarkers on the point of care in the emergency department. So thank you very much. Have a good day, everybody.
Thank you. Thank you, everyone. Bye.